after lunch. So please put up my slides. Thank you for being here to listen to us talk about women. It's a subject that I'm very passionate about because, as you can see, I'm a woman. So there's a lot of conversation around service delivery, but have we ever asked ourselves about if availability equals access? Because most of the time, we say key populations are left behind, but women who use drugs are left way, way, way behind. So I'll just give you a short background of Kenya, and my slides got an input from a few colleagues from the East Africa, so I will assume a lot of the notes I'm going to share will cover the region as well. So Kenya, we are in our 10th year of implementing harm reduction. We started off with NSP, and then after government drafted the guidelines, then OST came along. Approximately in the system, we have between 30 to 40,000 combined. Funding is 90% donor money. So if donors withdrew today, the people who use drugs in Kenya will have nothing. So women who use drugs have unique, significant unmet needs, which is environmental, societal, and individual factors. The limited data also makes it very difficult when it comes to implementing for stakeholders. So in Kenya, you find regions that are far away from Nairobi, like Busia, Kisii, Garissa. There are no drop-in centers at all. The drop-in centers that we have right now are concentrated along towns like Mombasa and Nairobi. So there's limited insurance options. If you went to the clinic to give birth, for example, it is not available for a woman who uses drugs. If you needed mental health care, Rita will tell you you'll have to remove money from your pocket to pay to be admitted. And this is not possible for people who use drugs. There's also limited social programs that support women who use drugs, and this is majorly because of funding. There's been a reduction of funding for community organizations, especially in the last 3 years. So even civil society organizations and drug user organizations that support people who use drugs have continuously lost funding. So I just wanted to show you a snapshot of our background. I got this from the media, and it's more of corruption and where part of the global fund money goes. So if it's corruption within government, what does that mean? That the money that trickled down to program is very, very, very small. And the one that will reach the drug user at the grassroots level is very, very small. But have we ever thought of ourselves and asked, how do we deal with government corruption? Do donors put this government to task? Do you ever come back and ask, hey, I gave you 5 million. Can you show me the numbers for this 5 million? We are now talking about community evaluation. How many donors follow up and ask, the women organization here, how many of you actually enrolled? And because there's corruption at government level, they also doctor the numbers. I'm not against UNODC, but it's high time you started speaking to community about numbers. So these are the experiences of some women that we talk to. We've done a lot of research in the last 3 years, and these are just some field notes that we've been collected as we collected our data. So the women who are engaged in harm reduction, they feel increased empowerment. They feel the autonomy. They feel they have the information. They feel the literacy, and they can actually tell you, yes, now I can take my child to the hospital. If that information is not there, she will not go to that access. She will not go to the hospital. Because if she has that information, then her family has it, her child has it. Then successful referral and navigation also contributed to the success of service delivery. If she came to the clinic, for example, if you go to an OST clinic, there's where they do the registration, then there's the place for counseling, there's the place where you get your methadone. If that process is successful, she will likely come back. But if she goes to the clinic and she sits there and you look at her like her makeup does not suit her face and you start twitching your mouth and saying, she looks bad. We had a very bad experience when we referred people who use drugs to our national referral hospital. It's called Kenyatta Referral Hospital. So we could take these people from, that is when I worked for CDC, we could refer these people from the field to go and get tested for HIV. But the moment they arrived there, they were being turned away because they're very dirty. And this person will never come back again. So these are some of the nuances that we should look at when we are delivering services. So lower health literacy among women who use drugs also cause them not to access services. They do not know. We need to do more work when it comes to creating awareness. So a lot of healthcare-related stigma. There's some research I did. I worked with a psychiatrist before, and we collected a lot of data on substance use disorders and the knowledge within primary healthcare providers. One nurse told me that she cannot put on her uniform when she's going to work because she does not want her neighbors to know that she's working in a mental facility. Why? Because the neighbors told her, because you work in a mental facility, so you also look like you have a mental problem. And in Swahili, there's a very bad word we use it. We say, umechizi. It's really derogatory, because if you feel you're trained and you're going to work, and the health profession is a noble profession, then why are you supposed to be working in a mental health facility? It's because our values tend to look at mental illness as demonic. Your neighbors will tell you, if you have a child that is using drugs, what do they say? Take them to the church to be prayed for. Like they'll beat out demons. So there's a lot of stigma, healthcare-related stigma, that we still see around the family, around drug use, and around mental health illnesses. We still see a lot of societal and structural stigma, even in learning institutions. If you went to the National Mental Referral Hospital in Kenya, 50% of bed occupancy are university students suffering from substance use disorders whose parents have either run away or have isolated them and they have nowhere to go. It is because the university does not allow them to get back to the system and get their scholarship once they get into addiction. That is how bad things are. But universities are for young people. And drug use, the highest numbers are between 18 and 25 in Kenya, according to the NACADA survey. So if you have the most affected population not getting back to the system, I mean, in Africa, if you use your university scholarship, then it's like you've lost your life. So why are we making policies that make it difficult for people to get back to their feet? But we say, on the same note, we say we want to help them. It doesn't make a lot of sense. So in as much as we are talking about drug policy reform, are we looking at institutional drug policies around schools, around universities? Because that is where we have the highest number of people who use drugs in Kenya. So there's a workplace policies, again. If I tripped off into addiction, which can happen anytime based on my mental health, and it can happen, it will be very difficult for me to go back to work. Because the stigma my colleagues would have labeled me, the judgmental attitude, they probably would have told the police, this one uses. Next time she comes, I'll call you so that you arrest her. Check her purse. And you go out and they say, probably she's now going to smoke. There's a judgmental attitude. So we find this in the workplace a lot. So we still need to create a lot of awareness so that people are able to come out, especially women, and seek services. There's a gap in information, a big gap. When harm reduction came, there wasn't a lot of information. And I usually call it was like a rocket launch. You launch a rocket and it goes up. And as it goes up, other parts are falling off. So a lot of things are falling off. The people who started harm reduction in Kenya who began like Rita in 2013, it was quite enjoyable. There were incentives, people were going to get treatment, there was a lot of information. The healthcare personnel were very happy. Then all of a sudden things that changed. It was just methadone and needles. So people who are getting on board now are not as not benefiting as people who got on board in 2013. Because in 2013, when we began, it was holistic. The information was there. Everybody was ready to welcome. This is harm reduction. This is what to expect. But that has been diluted with time. So we need to get back to information giving so that the women who get into the system, they know what to expect. I'm taking methadone. How does that affect my menstrual cycle, for example? How does it affect my gender-based violence, living with my husband, for example? If the methadone is going to affect my boyfriend's libido, how am I supposed to access that? Because that is also a source of gender-based violence within these couples. And they have no skills when it comes to negotiating, even for sex. So why are we working with women if we do not want to go the long haul? You cannot say you're treating a woman if you're not taking care of the sexual reproductive health. Just stop it. Stop it. It does not work. And there is no way you are going to provide services. And then you say now when it comes to sexual reproductive health, the government of Kenya will say, no, 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 no. We are withdrawing this bill on sexual reproductive health because the doctors are going to use it to procure abortion. That's what the politicians say. And then they say we are demonic. Then in the peer sites also, a lot of the OST sites, there's absence of people who use drugs. And I'll give you an example. You go to a clinic, the counselor is male. How are you going to tell the male you have an STI, for God's sake? I don't want him to assess my private parts. I would want a woman to do it. So there are sections in the healthcare system where you need to strategically place either a young person or a woman or a man for the benefit of the client. These are some of the small little, tidbits that programmers need to look into. Because you are so after, I was counting the targets when I was seated there and Guna was presenting. It was 90, 90, 90. There's 10, 10, 10. Then it is 80, 30, 60. Where are the people in all this? We are missing out on very, very small bits because we are not looking at the uniqueness of the individuals that we are dealing with. So if we well-thought programs, women will come out. I found women who use drugs in the home because of the nature of her caregiving. The family does not know she's using, so how will she get to the clinic? A peer worker needs to get there, a peer worker who knows that she's using, so that she can come out and get the services. Then we also don't have numbers. I don't know which Africa government has statistics. If my county, for example, wanted to do something in the social scene, they will ask me, give me the numbers. We do not have them. So why are we making noise if we do not have the numbers? It is very difficult to implement if we don't know how many people are affected. Then adolescents and young people, for God's sake, why are we programming without young people? There's no data. In Mombasa, we have as little as young as 8 years old in sex work, tourism, and drugs. But you go to the national statistics, they are not anywhere. But they need services. And then the policies say that they must be accompanied to the clinic. There's the policy on assent and consent. When you give a child treatment, and then they go to the clinic, then the clinician will go and tell the parents, I saw your child at the clinic today. She will not come back. So we need to start being creative when we are dealing with women, young women. There is sex work, and it is tourism, and it is drugs, and it's a young person underage. How do we deal with that? We need to start being creative. So there's high-level criminalization and stigma, yes, many overlapping subgroups, women who use drugs, sex workers, pregnant women, they all have unique needs. And then, of course, trafficked women. We have Somali women in Kenya. We have Ethiopian women in Kenya. They are engaged in, they are migrants. How do we reach out to them? So I have a few recommendations. There is no way we are going to do without sustainable livelihood programs. And I'll tell you this, we've done a lot of research. And when you leave people to survive on their own, they get in the hands of the peddlers, and it becomes very, very, very difficult. Because now you sort of become a slave. And women who use drugs have become a target for peddlers who use drugs in the streets. Tell me you don't know any woman who uses drugs, who sells a drug here and there to survive. It is not her own making. It is because the situation in her house and her children are forcing her to do this. So we need to rethink our programs, especially when it comes to women. We need to rethink how we do these things. We need to rethink how we collect data, and we need to rethink how we program. Thank you very much.